Schizophrenia versus bipolar disorder. To review, this is the normal brain anatomy. Let's go over the normal neurophysiology. The forebrain is broken down into two cerebral hemispheres, the basal ganglia and the diencephalon. The two cerebral hemispheres is divided into lobes by major sulci or grooves. The basal ganglia is a processing area that links cerebral cortices to thalamic nuclei to initiate, coordinate, and execute motor movements like walking. The diencephalon is made up of the thalamus and the hypothalamus. The thalamus is the relay station for sensory information. The hypothalamus is the maintenance of homeostasis and behavior patterns. So remember, the two cerebral hemispheres are broken down into lobes. The frontal lobe controls voluntary motor activity, concentration, motivation, self-monitoring, and Broca's area. The parietal lobe has somatic, receptive, and association areas. It processes all sensory data, including olfactory and auditory. The occipital lobe is a visual, receptive, and association area. The temporal lobe is the auditory center. It includes Wernicke's area, which is the reception and interpretation of speech. It is also involved in balance, taste, smell, emotion, and memory. The limbic lobe controls affect in conjunction with prefrontal area, and it mediates behavior patterns that determine survival. It is involved in memory, which is the control of transfer of short-term memory stores to permanent stores. It includes three very important areas, including the nucleus accumbens, the amygdala, and the anterior caudate nucleus. So now let's review the normal neurotransmitter function. First, we have dopamine. It regulates motor behavior in extrapyramidal nerve tracts and also transmits in the cortex. It increases vigilance and may increase aggression. Too much may produce psychosis, and too little may cause movement disorders. The next is glutamate. It is the most important excitatory neurotransmitter in the brain. It is important in memory and learning. Impairment in N-methyl D-aspartate, or NMDA, affects glutamate metabolism, which may lead to problems with cognition, delusions, and possibly some negative effects of schizophrenia. The next is serotonin. It is important in emotional states, moods, and body temperature. Finally, we have norepinephrine. It is involved in attention, consciousness, control of body temperature, and regulation of pituitary gland secretion. So what is schizophrenia? It literally means split mind, but don't get it confused with split personality. It is characterized as a disturbance and deterioration of cognitive, social, and emotional functioning. There is a loss of synchronized brain functioning that leads to thoughts, behaviors, and feelings that are disordered, disorganized, and disconnected from reality. So let's go over the etiology of schizophrenia. There is no exact cause of schizophrenia, and it remains unclear. The risk factors include genetics and an environment. For genetics, the children of two parents with schizophrenia, there is a 40 to 68% risk. Children of one parent with schizophrenia, there is a 9 to 16% risk. Non-twin sibling of a brother or sister with schizophrenia, there is an 8 to 14% risk. Prenatal infections and malnutrition, birth complications, and brain injury are associated with development of schizophrenia in persons with increased genetic risk. For environmental risk factors, increased stress and taking psychoactive drugs during adolescence and young adulthood increases the risk for schizophrenia. So what is the clinical diagnosis of schizophrenia? Most persons first diagnosed with schizophrenia are 15 to 54 years old. The most common age of symptom onset and clinical diagnosis is between 25 and 35 years in women and between 15 and 25 years in men. There is an emphasis on presenting clinical manifestations, which we'll be going over soon. So now let's go over the pathophysiology of schizophrenia. There are dopamine effects, glutamate effects, and neuroanatomic alterations. For dopamine, there's abnormalities in the dopaminergic pathways in specific regions of the brain. There is excessive dopamine D2 receptor activity, and elevations in dopamine increases positive symptoms, and decreased dopamine levels produces negative symptoms. Glutamate effects, there's decreased glutamate in schizophrenia, which may also play a role in related to innervation of the NMDA receptors, which is important for learning and memory. The neuroanatomic alterations, there's enlargement of lateral and third ventricles, widening of cortical fissures and sulci, reduction in frontal lobe blood flow and relative decreases in frontal lobe metabolic activity, reduction in thalamus and temporal lobe, and there's hypoactivity in the dorsolateral prefrontal cortex.
I'm too sexy for my love, too sexy for my love, love's going to leave me.
Hi Nana, I got you flowers.
Thanks.
Sorry I'm late. I was skating with my friend John Wallace. Hey John, have a seat.
I don't like your face.
What? Potatoes. I'm hungry. Let's eat.
So this is Nate and Anea. They're on their first date and they met the other night at 939. But they both have schizophrenia, but which one has positive and which one has negative?
My name's Nate, and I was displaying positive symptoms of schizophrenia, which include commonly disorganized thinking, unusual speech, odd behavior, delusions, and what was the last one, John? Oh yeah, hallucinations.
Hi, I'm Nanea. I just came from a horrible date with Nate. I was displaying negative symptoms of schizophrenia, which are more difficult to identify than positive symptoms. Common negative symptoms include dull or blunted emotional affect, social withdrawal and isolation, poverty of speech, posturing or remaining in one position for too long, and autism.
So let's review the common clinical manifestations of schizophrenia. Nate was displaying positive symptoms of schizophrenia, which are thought to result from excessive dopamine D2 receptor activity in the brain. Positive symptoms are usually more apparent and more obvious to the casual observer. Common symptoms include disorganized thinking, unusual speech, odd behavior, delusions, and hallucinations. The negative symptoms that Nanea was exhibiting are thought to be associated with dopamine D1 receptor activity in the brain. These are usually more difficult to recognize than positive symptoms. Some of the common symptoms include social withdrawal and isolation, dull or blunted emotional affect, poverty of speech, posturing or remaining in one position for prolonged periods, and autism. So now let's go over the nursing priorities. According to the North American Nursing Diagnosis Association, the nurse who is caring for a schizophrenic patient should set realistic goals, set desired outcomes, and set desired criteria for families of the schizophrenic client. According to Boyd, a suicide assessment should be performed, the patient should be kept safe, patients should be treated with antipsychotic medications, and during the chronic phase, patients need help accepting their illness and developing realistic expectations for the future. In addition, they should avoid social isolation. There are many nursing interventions that a nurse can perform with a schizophrenic patient. First, assess the patient's ability to carry out the activities of daily living, especially their nutritional status. They should maintain a safe environment and minimize stimuli, adopt an accepting and consistent approach with the patient, avoid promoting dependence, reward positive behavior to help patient improve their level of functioning, engage patient in reality-oriented activities that involve human contact, and if the patient is hallucinating, explore the content of the hallucinations. Do not tease or joke with the patient. Do not touch the patient without warning. Evaluate symptoms carefully and mobilize community resources to provide a support system. In addition, encourage compliance with the medication regimen to prevent relapse. So now let's talk about the treatment for schizophrenia. It includes antipsychotic medications, which are used to manage psychosis and both positive and negative symptoms associated with neurotransmitter dysregulation. Some first-generation antipsychotics are chlorpromazine, which has nonspecific neurotransmitter effects and numerous side effects. Haloperidol is used more often due to less anticholinergic and hypotensive side effects. Some atypical antipsychotics include clozapine, risperidone, olanzapine, and quetiapine. Atypical antipsychotics are primary treatment for patients with schizophrenia. New atypical antipsychotic medications are being developed with the aim to stabilize dopamine rather than reduce dopamine activity. Aripiprazole and ziprosidone are examples of these better balanced medications. Lastly, for schizophrenia, let's go over the nutritional interventions that a nurse can do. So due to hunger response changes, weight gain is a common side effect of pharmacological treatment of schizophrenia and causes many patients to stop taking their meds so they don't gain weight. Proper nutrition and exercise is an important intervention and patient education topic for patients with schizophrenia. So the nutrition approaches may include correcting blood sugar problems made worse by excess stimulant and drug use, addressing essential fat imbalances, increasing antioxidants with niacin therapy, addressing methylation problems helped by B12 and folic acid, and investigating pyroluria and the need for zinc and identifying any food allergies. So, well, how does schizophrenia compare to bipolar disorder? Well, bipolar disorder is a highly complex mood disorder. It is characterized by recurring symptoms of depression and elation or mania that can become severe enough to produce psychosis. So the etiology and risk factors for bipolar disease include the misbalance in serotonin, norepinephrine, and dopamine. Some evidence suggests that brain tissue changes contribute to bipolar disease. For the risk factors, the main is genetics predisposition. So the risk in monozygotic twins of a parent with bipolar disorder is 75%. The risk in a person with two parents with bipolar disorder is 60%. The risk in first-degree relatives is 20%, and the risk in general population is 1%. Like schizophrenia, bipolar disorder is diagnosed based on its clinical manifestations. It can be diagnosed as type 1 bipolar disorder or type 2 bipolar disorder. Type 1 requires one episode of mania and major depression. Type 2 does not require any episodes of mania, but does require at least one episode of hypomania and major depression. Symptom onset leading to initial diagnosis of bipolar disorder typically does not occur before late adolescence or early young adulthood. It is sometimes difficult to diagnose. So let's go over the pathophysiology. Remember, in schizophrenia, there are dopamine, glutamate, and neuroanatomic alterations. In bipolar disease, there's a alteration in serotonin, norepinephrine, dopamine, and there are neuroanatomic alterations. In the first hypothesis of bipolar disease, it says that the assumption is that depression and mania of bipolar disorder are the result of two different neurobiological processes. The first one is neurotransmitter deficits are thought to promote depression, and the second is the neurotransmitter excess is thought to promote symptoms of mania and psychosis. The second hypothesis says that bipolar disorder is a result of a specific form of neurotransmission dysregulation that results in the loss of mood stabilization. And like schizophrenia, there are neuroanatomic alterations like ventricular enlargement, increased numbers of T2 signal hyperintensities, and tissue loss in the basal ganglia, lateral and mesiotemporal structures, and cortical regions, leading to impaired emotional processing and impaired regulation of emotional behavior. The common clinical manifestations of bipolar disorder include mania, hypomania, and depression. In mania, there is an overwhelming increase in energy and drive, leading to nonstop activity. There is grandiose thinking, impulsivity, impaired judgment, acting out behaviors, and hypersexuality. In hypomania, it is similar to symptoms of mania but does not include loss of reality, psychosis, or impaired functioning. And in depression, there is a sudden onset of symptoms and it is similar to major depression, including the hallmark symptoms of a depressed mood and loss of interest and pleasure. Now the bipolar besties will show you these clinical manifestations.
I got this feeling on the summer day when you were gone. I crashed my car into the bridge. I watched, I let it burn. I threw your shit into a bag and pushed it down the stairs. I crashed my car into the bridge. I don't care. I love it. I don't care. I got this feeling on the summer day when you were gone. I crashed my car into the bridge. I watched, I let it burn.
Guess what? I dyed my hair. Oh my god! I did it! Oh my god! Yeah! Oh my gosh. Why did you dye your hair? Oh my gosh, guess what? I got an art interview. Oh my god! I know. Guess what? I got into clown school. Yeah! My dream job. Oh my god. Oh my god. Finally gonna be an artist after like 5 years. Finally gonna be a clown. Oh my god. I know. You're gonna be the great clown. Oh my gosh. You're gonna be great art. Oh my god. The manager's gonna love it. Love it. You think I'm gonna get hired? Yeah. Oh my gosh, I'm so excited. You think I'm gonna be a good clown? Yeah, you're gonna be perfect. Oh my god. Okay. Yeah.
god, Giovanna, guess what?
What?
I was reading my admission letter. I actually got rejected, not accepted.
Oh my
so I don't know
God.
what I want to do with my life. I dyed my hair. Actually, I didn't. It's a wig.
Oh my gosh, mine too. But you know what? My manager hated it. He didn't even hire me. And I called like every single day until they finally told me I didn't get the job. I'm gonna be a nurse aide for the rest of my life.
I don't know what I'm gonna do with my life. I didn't even go. I was just getting ready to go to clown school. I have nothing going for my life. I want to kill myself. Oh my god. Ugh. My name is Joni. I was displaying bipolar disease. There are two types of bipolar disease. Type 1 bipolar disease includes 1 episode of mania and 1 episode of major depression. In type 2 disease, there are no episodes of mania, but there are episodes of hypomania and an episode of major depression. The common symptoms of mania include an increased energy and drive, which leads to non-stop activity, grandiose thinking, impulsivity, euphoria, impaired judgment, acting out behaviors, and hypersexuality.
Symptoms of hypomania are similar to mania, but without loss of reality, psychosis, or impaired functioning.
Depression, or dysphoria, has a sudden onset. The hallmark symptoms of major depression are depressed mood and loss of interest and pleasure.
So here are the nursing priorities that should be established for a bipolar patient. During manic phase, protection of the patient is a priority. Poor judgment and impulsivity can take place and can have dire consequences for the patient and family. During a depressive episode, the patient may feel that life is not worth living. Patients should be monitored for safety. The nursing interventions include observing the client every 15 minutes. If the patient is suicidal, remove all dangerous sharp objects from the room. Reinforce that the patient is worthwhile. Assist the client in evaluating the positive as well as the negative aspects of her life. Encourage the appropriate expression of angry feelings. Schedule regular periods of time throughout the day for recreational and occupational therapy. Ensure clients' participation in taking mood-stabilizing medications. Engage the client in interpersonal therapies and cognitive behavioral therapy. Encourage the client to attend a group therapy. And lastly, encourage the client to journal their episodes. Lastly, this is how you treat bipolar disorder with the pharmacological interventions. The mood stabilizer stabilizes the mood and manages manic and depressive episodes. Lithium is a primary treatment for patients, but there is an increased risk for lithium toxicity. The therapeutic range is 0.8 to 1.2. Anticonvulsants such as divalproex are used if patient is unable to tolerate lithium. These drugs also have neuroprotective effects. Atypical antipsychotics are also used to treat bipolar disorder, including olanzapine, risperidone, quetiapine, and ziprasidone. These drugs are helpful because it exhibits a range of dopaminergic, serotonergic, and norepinephrine effects that improve bipolar symptoms. Aripiprazole is a drug that is known to be used with patients with schizophrenia. However, research has shown that this drug is effective for bipolar patients as well because of its dopamine and serotonin 5-H2 agonist characteristics and modest antagonist characteristics of 5-H2. This drug is used to manage mania symptoms. It is recommended as first-line option for short-term treatment of mania associated with bipolar and first-line or second-line for preventing recurrence of mood episodes during long-term therapy. So finally, let's go over the nutritional interventions for bipolar disease. Salt intake needs to be balanced with lithium therapy, and once a stabilized lithium dose is established, salt intake needs to remain constant. The nurse needs to monitor for caloric intake, exercise and weight, and nutritional imbalances like essential fats, blood sugar, and magnesium.
It's been a good time together, looking for the warmth of the sun. Gonna be a long time together, and the best is yet to come.